रिकॉर्डिंग ये किसने बोला? रिकॉर्डिंग अभी अभी नहीं करना है आपने तो कौन से मतलब जब एक्चुअल शुरू होगा तभी रिकॉर्डिंग तभी से करते हैं तो स्टार्ट करती हूँ इवन इफ यू सेम थिंग राइट नाउ नॉट एबल टू हियर एनीथिंग कोई बोल भी रहा है कि मुझे वो भी नहीं Dr. Mundi, can you once share your screen if मुझे आपको
Yeah, I can share my screen. Should I?
I made you co-host. Can you try sharing?
Are you able to see?
Yes, yes.
Thank you.
Good afternoon, Dr. Saab.
Good afternoon, sir. Good afternoon.
Yes, yes. Nice to see you.
Same here, sir. And what I'll do, I'll take this out.
Yes, yes.
Yes, yes, perfectly fine, sir. And voice पण clear आहे. So we'll stop sharing for now. And
Sorry?
Good afternoon, Dr. Saab.
Good afternoon.
Yes, yes. Nice to see you.
Nice to see you, sir.
Dr. Gayatri and Dr. Nitin, we are also आवाज येतोय Dr. Nitin?
Oh, yes, yes.
So we are also live streaming in on YouTube as well. So in case अगर ऐसा होता है कि हम लोगों को जरूरत पड़ती है तो उसकी लिंक हम लोग पार्टिसिपेंट किसी को जूम पे ज्वाइन करने में दिक्कत होती है तो वहाँ पे हम लोग बोल सकते हैं कि एक बार सेशन शुरू हो गया तो फिर उसके बाद आपस में बोलना मुश्किल होगा ना तो मैं आपके व्हाट्सएप पे मैसेज डाल के रखा है लिंक पे लिंक का मैसेज गायत्री के इस पे और आपके नितिन जी आपके इस पे
ओके 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 उसको शेयर कर दें क्या अभी?
अभी नहीं अगर यहाँ पे 100 क्रॉस होता है तो फिर अपने को एकदम से गड़बड़ हो जाती है ना वो टाइम पे या लेक्चर चल रहा है तो बीच में फिर इसलिए मुंडे सर यू कैन स्टॉप शेयरिंग फॉर नाउ
Okay.
we'll wait for 5 minutes Dr. Gayatri.
Yes, we will start in 5 minutes.
Yes, correct.
Okay.
Thank you.
हाँ, क्या दिला ना हाँ नाही हो ना नाही ऐक ना तुला मी नेक्स्ट टाइम सांगते ना काय असेल तर प्लीज मला
We should start documenting. So, sir, चालेल start केलं का? Start केलं तर चालेल. आवाज येतोय का माझा? हॅलो.
Dr. Rupa, can we start now?
आवाज येतोय का माझा?
नाही, क्लिअर नाहीये. व्हॉल्यूम खूप कमी आहे.
Is it better now?
हा, इट्स बेटर.
Yeah, okay. Then I think we're done. Yes, so we will start. So good afternoon, everyone. We welcome you all on behalf of Mukta. As you all know, Mukta Charitable Foundation has always been bringing different important topics in relevance with our clinical practice to make our practice little more rational, ethical, and practical. And in that line, today we have some very important topic on renal cause with us. Before starting with the session, here I request Dr. Mansi Pawar, who is organizing chairman of the Medicon conference, to introduce the participant about the Medicon conference for 2 minutes. Welcome, Dr. Mansi.
Thank you, Dr. Rupa. On behalf of MCF Mukta Medicon 2024 Organizing Committee, I invite you all for Medicon on 9th of June, Sunday, at Bharti Hospital Auditorium, Pune. Many of you must have attended last year's conference. It was really interesting and everybody was excited. Everybody enjoyed the conference. So this year's scientific content is also almost ready and we'll be sharing it with you soon. We are happy to announce that two Padma Shri awardees, Dr. Raman Ganga Khedkar sir and Dr. Himmatrao Bavaskar sir, have accepted our invitation to be chief guest and guest of honor for the conference. We all are excited to hear them and meet them. I sincerely request you all to register for the conference at the earliest, as we have limited seats for the conference. The link for the registration will be shared soon on the WhatsApp group. So see you all in person on 9th of June at Medicon 2024. Over to you, Dr. Nimbane and Dr. Rupa.
Yes, Dr. Nitin Nimbane sir, who has his huge practice in Baner area. I should say student of Dr. Prakash Mahajan, but a very well-known doctor, a very good friend of Mukta Foundation. And here we have today Dr. Nimbane, who will introduce the speaker and will be with us for question answer discussion. Dr. Nimbane. Mute.
Okay, thank you, Rupa. Thank you for your kind words. Today we are going to listen from a well-known doctor, nephrologist, Dr. Suhas Monde. He has done his DNB General Medicine from Pune Hospital. He has done his DNB Nephro from Care Hospital, Hyderabad. He has got various fellowships. They are fellowships in solid organ transplant from University of Ottawa, Canada, fellowship in glomerulonephritis, fellowship in clinical nephrology from Western Ontario, London, Canada. He has also done his diploma from Royal College of Physician and Surgeon from Canada. besides that, he has done various courses. They are courses in courses of International Society of Nephrology, courses in nephrology certificate clinical medicine, and a course in advanced clinical nephropathology certificate course. The biodata is huge and lengthy, but I suppose for the want of time, I would request Dr. Suhas Monde to start his lecture. Dr. Suhas Monde, sir.
Thank you. Thank you all of you for this kind invitation. It's always an honor to talk to so many people who are interested to listen to you. So thank you so much for this opportunity. I'll be happy if we can like give more time for question answers, because that is more which will help both of us. Okay. And for the same matter, I'll keep my discussion as a short so that the question answers will be more. I am happy if someone wants to interrupt me, wants to ask something, wants to describe me something, but don't hesitate to ask. Okay. So that's first and foremost request. Second, as I mentioned that I'll be sharing screen now, but is it okay?
Yes,
Yes,
yes.
sir.
Okay, thank you. So the topic is evidence-based pearls of wisdom to avoid pitfalls in recognition and treatment of frequent insults to the kidney. Here, definitely I'll be talking all evidence-based. So anyone needs any evidence of what I'm presenting, the description link will be at the bottom of the slide, or you can like ask me anytime. But I'll be happy to provide the evidence of each and every word that I am mentioning. And something that we want to avoid is a frequent insults to the kidney, and why that we will be seeing for sure. Okay. To start with, I would like to say that this is a teamwork. Okay. Nephrologist alone cannot help the patients. Okay. And it's like a teamwork of a diabetologist, family physician, dietitian, physician, nurses, physiotherapist, patient himself, so that we can get the betterment of the patient to improve the patient's condition. So if someone feels that the nephrologist will be able to help the patient alone, that's definitely not the case. Okay. So the disclaimer for this discussion is that obviously there is no financial disclosure or conflict of interest, but I'm here to save some more kidneys. AK has been like close to my heart for all the time, and I'll show you why we need to be like more vigilant about the kidney injuries than any other organ dysfunction. So the pulse of wisdom, the pulse which I'll be discussing about is first, what is EGFR, diabetic control, hypertension control, proteinuria control, active sediments, how to assess the renal protection, why AKI treatment is important, what are nephrotoxicity, fluid and diuretics, some blind spots in kidney, and radio contrast and vaccines. Okay, these are just the topics which this is the pathway of my discussion. Okay, so the first and most important part of discussion is that today almost 17% of population is having kidney disease. Whether they are aware of it or whether they are not, that's the topic of discussion. But 17 out of 100 are having kidney disease. The stages might be different. Most of them will be in first and second stage. The few must be in third and fourth stage, and there will be very few in the fifth stage. Yes, but there will be chronic kidney disease, which is more prevalent along with diabetes and hypertension. And the most reason for that is because most of the time the kidney injury goes unnoticed. It doesn't happen overnight. It happens over a period of time. Initially, there will be just increased risk, which with ongoing damage will show changes in the kidney morphology and labs. The persistence of that damage will be resulting in the kidney failure and the list of complications which all of us are aware. So that's why we need to protect the kidneys in each and every possible way so that we can avoid the complications. This part will be like eye-opener for most of us, because the hypertension treatment nowadays, along with the labs and medicines, will be costing like few hundred rupees per month. Antihypertensives, once in a while, cardiac evaluation. It just 100 hundreds of rupees. For diabetes, obviously the labs are more, the glucometer, the strips, the charges are more, insulin is costly. Nowadays, the newer insulins are more costly and it will cost like thousands of rupees. The prevalence of hypertension and diabetes are huge, but the cost is not that great as compared with kidney disease. If the patient is not on dialysis, the patient still will be paying for labs, medicines, procedures like fistula creation, recurrent hospitalization due to infections, the cost for antibiotics, erythropoietin, and the costing goes to 10 to 15,000 per month. And if the same patient goes to dialysis, the cost goes to 30 to 50,000 because dialysis itself is a costlier thing. Even though nowadays that there are subsidies available and the charitable dialysis centers are available, still the quality is something which needs to be focused more than just the cost in dialysis. So that's why we need to protect the kidneys in each and every possible way. The first topic that I want to mention is regarding this. This is a routine lab result of any of the labs where the creatinine is mentioned and next to it there is a reference value. The reference value is very much fake in terms of kidney disease. And the reason is because suppose someone is having a creatinine of 1.25, that patient is a 20-year-old female. If we put into the calculator, eGFR calculator, for the same 1.25 creatinine which was told by the labs as normal, it will show that GFR of 63, which is already a CKD stage 2. But suppose if the same report is of a 65-year-old female with the same 1.25 creatinine which was told as normal by the lab, the GFR will be 48. This is eGFR calculator. This is just to tell you that creatinine itself doesn't give you the understanding about the kidney disease. We need to evaluate eGFR of each and every patient as per his gender and age, so that we'll be understanding the kidney function in detail. CKD stage 3B is 48 ml. So even though creatinine looks normal, the patient will be having CKD stage 2 or stage 3 depending on the age, and sometimes it's just probably enough to miss the diagnosis in initial few years, which is very crucial for the patient's condition. So we need to focus on eGFR all the time. There are now labs which are moved from writing creatinine to eGFR for the same purpose. And I think we should be focusing for the same. Okay. The next part is that better diabetes control. Every time we tell the patient that yes, we are monitoring your HbA1c and the control should be better. But understand how much better is good. If the HbA1c drops from 7.3, which is probably most of us will accept as a good control, if it is better from 7.3 to 6.5, it will reduce the risk of new onset nephropathy or worsening of the pre-existing nephropathy by almost 21%. So 1 in 4 almost patients or 1 in 5 patients will be saved their kidneys just by dropping HbA1c by 0.8. And that too also essential in the very early part of the kidney disease, not in the later. Okay. So yes, better diabetic control we should be insisting upon, but it should be the lowest possible without complications. And this is a NEGM study. It's not like a routine evaluation or observation. This has been like a multi-centric double-blinded studies which were done to show this amount of evidence. The next is that strict blood pressure control. Many times we do tell patients that the blood pressure needs to be controlled. It should be 130/80 or 140/80. Sometimes the blood pressure number is just arbitrary. We need to have a blood pressure in a better control way to decrease the protein loss so that the overall kidney function will be better over a period of time. But how much is better? There are newer studies like SPRINT trial or ACCORD where they are mentioned that if the blood pressure is too tightly controlled, it will cause giddiness, it will cause hemodynamic disturbances, which will probably cause more acute kidney injuries. So the lower the better sounds good for diabetes, but not for blood pressure. In blood pressure, the lowest possible blood pressure achieved with medicines and lifestyle modification without complications or without the symptoms of postural damage or worsening kidney injury is the good control of blood pressure. And again, there is an evidence of this, which is a multicentric double-blind study, where we have studied with the intensive blood pressure control versus routine blood pressure control. The third is protein loss. Very oftenly we get urine routine for the patient, but we don't estimate the exact amount of protein loss, how much 24-hour of urinary protein excretion is there. And here is the graph which shows that if someone is having just less than 30 milligrams of protein loss in a day, the progression of kidney disease over a period of 10 years is just minimal. But for the same patient, if the protein loss is more than 30 to 300 versus 300 to 1 gram or more than a gram, the progression is huge. So that is something which makes us understand that we should be able to quantify the proteinuria of each and every patient, so that we can understand that with treatment, how much protein loss has gone better and how much the risk of worsening kidney disease has decreased for that patient. So suppose someone is having a diabetic nephropathy with more than a gram of proteinuria, that person will reach ESRD definitely in the next 10 years, just because of the proteinuria, not related with the diabetic control or hypertensive control or any other pathology. So if someone is having added risk factors of the ones which I mentioned, definitely the progression will be faster. The patient will be reaching ESRD not in 10 years, but just in couple of years. And we have evidence also that if we decrease the proteinuria from, suppose from 3 grams to 0.25 grams per day, the progression is much slower, and patient will be able to have a good kidney function for years together before reaching to the advanced kidney disease stage. Coming back to the urine routine, many of times our patients show urine blood positive. The most probable diagnosis in that scenario is urine tract infection or the kidney stones, but not always the patients present with the symptoms of urinary tract infection. And at that time, the possible diagnosis could be glomerulonephritis. The patient might be having underlying IgA nephropathy, membranous proliferation, or might be membranous nephropathy, focal segmental glomerulonephritis. There could be a diagnosis like a fibrillary or immunotactoid nephropathy. So there are huge amount of spectrum of kidney disease which will be missed if we misinterpret as a urine blood positive as just a urine tract infection and treated with antibiotics. So we always need to make sure that if there is a urine blood positive, or even sometimes that patient presents with the pus cells in the urine, but no symptoms of urine tract infection. Actually, this pus cell is a misnomer. We should not be using a pus cell word over there. The word should be WBCs, because these are the white blood cell counts. So white blood cells in the urine not only could be because of infection, but also inflammation. The inflammation of the glomeruli or the filters of the kidney. And that will be leading again to the glomerulonephritis. If there is a suspicion of, sorry, any questions?
No, sir. No, sir.
Okay, so if there is a suspicion of glomerulonephritis, what are the easiest way? First of all, we can definitely find out whether there are dysmorphic RBCs. The RBCs or the blood cells which are present in the urine, whether they are dysmorphic or not. And this is just a simple test which can be done in the routine urine microscopy only. Sometimes we may need to get a serology testing like a ANCA vasculitis, like a MP or PR3 or ANA, dsDNA or complements. And if at all there is no diagnosis which was meant out of it, we need to go ahead and get the tissue diagnosis to rule it out that which type of glomerulonephritis we are dealing with. Why we need to reach out that? Because each glomerulonephritis is having a very different progression. Some of them, they progress very slowly, some of them are very rapid, and depending on that, all the comorbidities and mortality will be decided. The next part is that sick day medication. This is probably which I see most in my practice. Okay. If someone is sick or not hydrated well, having a diarrhea, nausea, vomiting, then definitely the medications which that patient is taking for renal protection causes kidney injury. So there is a list of medication like sulfonylureas, AC inhibitors, ARBs, NSAIDs, SGLT2 inhibitors. Nowadays, dapagliflozin or empagliflozin is being used very rampantly. But if someone is not well, if the patient is sick, this medication needs to be avoided. Even though these are the best medication to cause a renal protection, in the scenario of decreased hydration or dehydration or hypotension, these medications cause severe AKI, and that is most of the time in the form of acute tubular necrosis, causing patients to have a kidney injury. So when we mention that how to protect the kidneys from recurrent insults, yes, we need to make sure that we tell them each time that you are on these medications, and these are the medications called as sick day medications. And next time, if you are having any of the kidney or any condition where you are not well, please stop this medication and talk to your doctors, because if you keep on taking this, you will land up in the recurrent acute kidney injury. Why we are worried about acute kidney injury? We are, yes, so sorry, before that, going to so many times we start patients on AC inhibitors and ARBs. Suppose there is a patient, two set of patients, one patient with a creatinine of 1 started on ARBs, and another patient of diabetes or hypertension who was started on ARBs. If there is a rapid worsening of creatinine, that means there is some pathology which has been missed. Normally, whenever we start someone on AC inhibitors or ARBs, the creatinine goes up by 30%. But if there is a rise of creatinine more than 30% from the baseline, there has to be some other pathology like a renal artery stenosis or underlying chronic kidney disease, which is worsening the kidney function in a very rapid way as compared with the creatinine being just increased by 30% and been stable for years. So this is something as a red flag. If we monitor the kidney function regularly, we will be able to diagnose it early. Sometimes there could be drug interaction also. If we start the patients on diuretics and ARBs or AC inhibitors at that time, because the patient probably was not hydrated well, or there was no need of the diuretics, or might be having a over diuretic effect, we will be seeing an acute kidney injury, which could be because of the just drug interaction and nothing else. So at that time, we need to identify what was the culprit, stop that treatment and see the effect. Most likely, it will be a good 30% rise and being stable for over a long period. I would like to share this case. I discharged this patient yesterday. This is a 40-year-old male gym trainer, diabetic, was newly detected. He came with HbA1c of 8.9, hypertensive, which he was noted for last 2 years, but not monitor the blood pressure that often. He was taking 2 tablets. One was telmisartan with chlorthalidone, another was cilnidipine with metoprolol. He was an athlete. He used to play great games. He is like a regular cricket player. And on Sunday, he had a severe backache, and for which he thought that it's a muscular origin. Took some tablets and was complaining that he has not having urine output since last 8 hours. So 40-year young, but when we check the creatinine, it was more than 3. So in that scenario, if we see, probably most likely the culprit was this tablet which he was taken. But if you see thoroughly, or if you see in detail what all were the risk factors, so first one was high muscle mass. Muscle generates creatinine. It's not only the kidney function which dictates the creatinine value, it's the muscle mass also. If someone is like a Dara Singh versus someone who is like a Keshto Mukherjee, obviously because their body mass is different, they will generate different amount of creatinine despite of normal or same kidney function. Second, diabetes mellitus. Diabetes mellitus, when it's uncontrolled, it's a glycosuria, which is like osmotic. Glucose is like an osmotic diuretic. So he was like having a inbuilt osmotic diuresis ongoing. Third is hypertension. We don't know whether the hypertension was controlled for last these 2 years or not. The fourth thing was telmisartan and chlorthalidone. Again, ARBs and diuretic. So there was one diuretic, 2 diuretics along with ARBs. Then next, patient took some tablet for muscle pain. Most likely it was diclofenac. He showed me the tablet, so it was diclofenac. So it was the one more culprit. And on top of that, because he was a athlete who was playing outdoor, he was not having a habit of keeping his hydration good. So it's not one or two or three. It's like many multiple risk factors which were responsible for causing AKI, and because of which his creatinine went up to 3. So what I did nothing actually. I kept him in hospital. We stopped all the medications. We hydrated him. The creatinine dropped from 3 to 1.1 within 48 hours. So now he realized that there are like so many risk factors which he needs to tackle and need to have a regular follow-up so that his kidneys will have a good kidney function. Most of the gym trainers are also used to get like artificial vitamin D. I still remember one of my patients who used to take veterinary vitamin D, and because of that, he will end up in getting a hypercalcemia and FSGS, focal segmental glomerulosclerosis, losing his kidney just because of these veterinary preparations of vitamin D. So if someone is taking unnecessary vitamin D, definitely it is not good because hypercalcemia causes diuresis, causing AKI. This is the natural history of kidney injury. When we are worried about the frequent insults to the kidney, we need to see this diagram, and this is probably one of the best diagram in my nephrology life for last 20 years at least. So here, if someone is having an insult, how that patient will do post insult will be depending on many factors. First, what the insult is, how long the insult was, what was the underlying kidney function, what were the risk factors, what was the kidney reserve. So there are some insults, like suppose a hypotension in pregnancy. Many a times we see that a single insult of hypotension in pregnancy causes acute cortical necrosis, which is irreversible, and patient goes to dialysis directly. It doesn't like progress from creatinine 1, 2, 3, 4, 5, 6. No, the patient directly goes into acute cortical necrosis and gets back on dialysis for lifetime. There are other like underlying diabetic nephropathy or hypertensive nephropathy with multiple comorbidities will develop AKI on CKD. But if there are like multiple AKIs on CKD, the patient will reach ESRD sooner as compared with his contemporaries with no underlying risk factors. Sometimes if the insult is longer, there is a sepsis or a hypotension, or patient has taken painkillers for long, that AKI will slowly progress into chronic kidney disease, and obviously that will progress because of the decreased number of functioning glomeruli. There are some few lucky people who gets an insult, had underlying risk factors, but still they recover completely, and those probably should be the most luckiest people who will be having good kidney function for long. This is something probably is one of the like basic diagram to explain how the kidney perfusion is. Probably kidney are the only organ where there is a venous or capillaries which are preceded and followed by arterioles. There is no organ in the body where there is a capillaries which are having before and after lined by arterioles. Arterioles are having muscular layer so that they can constrict and regulate the blood flow. So if suppose there is a blood flow coming to the kidney is good, there will be filtration, there will be normal GFR, and there will be blood which will taken care in the efferent and will circulate to the tubules. But suppose if there is a low blood pressure, there will be response in the form of increased prostaglandins, which will increase the blood circulation by afferent, and same prostaglandins will help the perfusion of the glomeruli. Because of the hypotension, there will be activation of the renin-angiotensin system, which will constrict the efferent, and because of this, the perfusion of the glomeruli will be preserved. So even though there is hypotension, the kidney will do autoregulation so that the GFR is maintained. But suppose what will happen if we alter this course in terms of pain medications or NSAIDs? NSAIDs decrease prostaglandins, so whatever afferent dilatation has to happen will not be seen or it will be absent just because the prostaglandins were removed by NSAIDs. And because there is a hypotension, there will be RAS activation, which will constrict the efferent. So this is also constricted, this is also constricted, so that the GFR will drop and patient will get acute kidney injury. The another factor will be, suppose someone is having AC inhibitors or ARBs and developed hypotension. So in that scenario, because of AC inhibitors and ARBs, the angiotensin receptor will not be there and the efferent will be dilated. And if there is a decreased blood circulation to the glomeruli, but efferent is not constricted, it again will not make any filtration and the GFR will drop. So this is the basics for sick day medication and why we should have some of the medications which are mentioned in the list to be avoided if someone is not hydrating well or having a sick. Very commonly we use diuretics, probably after pain medication and dolo, probably diuretics are most commonly seen with the general population. The reason because of that is we feel that diuretics will increase the blood circulation or improve the urine output, and once the urine output is good, everything is solved. But that's not the case. So this is a focus point of ultrasound which we have done in our ICU, where if the IVC, inferior vena cava, if it is dilated and you give diuretics, then only the patient's kidney will be saved. If there is no IVC dilatation or rather IVC is collapsed, that means the patient's hydration is not enough. Either there might be hypoalbuminemia or might be underlying cardiac condition or might be sepsis or decreased perfusion. But if the IVC is collapsed and if there is a decreased urine output because of this, diuretics will actually cause more harm than benefits. So we need to make sure that if we are using a diuretics, what is the current or what is the clinical scenario where it will be helpful. Diuretics, as I mentioned, needs a little bit more understanding. If someone patient we start diuretics and the creatinine started going up, that means there has to be some reason for that. Either the patient is not in fluid overload, or there might be intravascular depletion, or rather there is a drug interaction which is happening causing the kidney function to go south. The second, many times in ICU I see that the diuretics are given all around like PID dosage or like QID dosage of diuretics. Loop diuretics, especially like a furosemide or torsemide, will not act if they are given over a period of time. It's because there is a tachyphylaxis. The channel gets exhausted, and instead of actually having urine output throughout the day, after 18 to 20 hours, instead of diuresis, these patients will start absorbing more and more sodium, causing fluid gain. So that's why we normally suggest to give diuretics twice a day and give at least good 8 to 12 hours of gap in between the two doses of diuretics so that the channel regenerates and the effect of diuretics can be preserved. If someone is having huge pedal edema or huge edema, anasarca, in that scenario, because of the severe gastrointestinal edema, the absorption of diuretics is not good. In that scenario, the same dose of diuretics given IV will be having more beneficial or much more effect, robust effect as compared with oral medication. And that we always need to keep in mind what is the hydration level of the patient, what is the anasarca, how much will be the GI edema to decide the diuretics. Breaking phenomenon or the post-diuretic sodium reabsorption, that's what I described initially, that over a period of time, because we don't break the diuretics effect, the channel get exhausted, and because it gets exhausted, the diuresis will be lesser. And on the contrary, in the distal tubule and in the collecting duct, there will be more and more EMAC channels. These are epithelial sodium channels, which will be created by the kidney so that they will absorb the sodium. So even you block the DCT, distal convoluted tubule, the sodium and water will be absorbed in the collecting duct, which will make the effect of diuretics not much effective. Again, if, as I mentioned, that if someone is not hydrated well or intravascularly depleted, these patients will be having more of RAS activation, renin angiotensin aldosterone system activation, which will cause more and more salt and water retention. So on the contrary, to have a diuretic effect, if you keep on giving diuretics round the clock, the patient, instead of losing weight by day 2 or day 3, they will start accumulating more and more weight, which will make the use diuretics useless. The next is antibiotics, and we need to calculate the EGFR or creatine clearance to justify the dosing. Because if we use the full dose of antibiotics more than helping, sometimes these antibiotics causes interstitial nephritis, making them as like harmful to the kidneys. So every time when we use antibiotic which is renally excreted, we always need to make sure that we are giving it at the correct dose, and that to also making sure that whether we are giving it over infusion or at a single dose, depending on their bioavailability, where there is a sometimes there is a peak concentration of the antibiotic which we need, sometimes there is a area under curve of the antibiotic which we need to decide about the dosing of this antibiotic. So EGFR and creat clearance of EGFR or creat clearance of the patients who are admitted or on diet antibiotics, we need to keep a monitoring for that. I would like to tell this patient, he is a very good family friend of ours. The uncle, despite 60, is still a young, and visited Pune recently. And during his visit, he mentioned that he is getting pedal edema, which is nowadays more frequent. On evaluation, found to have creatinine which was increased. His baseline creatinine was around 2.8, and the day we met was 4.2. He had like high uric acid. Uric acid was 12 for him. He had like severe metabolic alkalosis. I'll show you the ABG. The pH was like 7.61. And I mentioned to them that there is something wrong. So the patient was followed by many doctors. He was followed by a diabetologist, a cardiologist, a nephrologist, and his friend. His one of friend was also a doctor. So he was taking prescriptions from all of them and taking all these medications, which is definitely wrong on the patient's part. They should disclose the patients like what other treatment they are on. But because they don't share, just because of fear of, or like sometimes it's just that their ignorance, they land up in taking many medications which are probably not useful to them. So this uncle or gentleman was taking 5 antihypertensives, out of which 3 were from the same group, and along with them he was taking 3 different types of diuretics. So the reason for this was nothing much but the drug interactions. Sometimes even I have seen patients who were supposed to take anti-diabetics, instead of just they were sounding like some other medications, were taking anti-allergic medications just because they were sounding together. So that something is like a very commonly we feel that needs to discuss along with the patient, so that, or otherwise see the prescription or see the medications or ask the patient to bring all their medications and just go through them to understand that what all interactions are happening for this patient. This is something which is very important aspect of renal practice. Suppose there is a patient who is on known diabetes for last couple of years, diagnosed to have proteinuria, which is almost like half a gram, was also detected to have a high blood pressure. The blood pressure was staying around 150/70, and creatinine on first visit was found to be 1.8. So for this patient, for the young 40-year-old patient, the creatinine is 1.8, which is CKD stage 3B. To be very honest, just for the diabetes for 3 years and few years of hypertension should not be causing kidney injury. We have seen that at least it should take like many years for diabetes, even though there is a proteinuria, should take many years to reach to the stage of end-stage renal disease or hypertension to be associated with it. So if there is no diabetic retinopathy and there is no possible glomerulonephritis associated, like no lupus or no ANCA vasculitis, in that scenario, the best possible way to understand is the getting kidney biopsy, because the prevalence of non-diabetic renal disease is almost 18 to 62%. So almost half of them. So we assume that sometimes the patient is having diabetes and hypertension and proteinuria. Okay, this must be diabetic nephropathy, but no, these patients might be having something else. They might be having underlying monoclonal gammopathy, might be a myeloma or IgA nephropathy or membranous nephropathy, and we will be missing diagnosis if we just keep the presumption of diabetic nephropathy as our background. So always, if there is a rapidly worsening renal functions or atypical signs present in the patient, the urine routine morphology is different, the kidneys are not looking great on the ultrasound, assume that there is something else which has been happening and missed. Hydration. Many of my colleagues I've seen hesitant to use a contrast in a patient. They feel that the contrast is something which will injure the kidneys and will not be able to give a what justification to the patient if there is a rise in creatinine. But understand, if there is a need which will need a contrast study like a CT angio or cardiac evaluation, and if you don't do it, probably will miss a very important diagnosis which can be responsible for the kidney dysfunction later. So it's always useful to understand the risk, avoid the nephrotoxic medication, giving hydration. Earlier there was a N-acetylcysteine or like some taurine, but nowadays it has been proved that just hydration before giving a contrast and after giving a contrast should help to salvage the kidney function. And along with that, someone can use even a low osmolar contrast agent. At our place, we use something like Omnipac, which is like an isoosmolar contrast agent, which will be helpful for getting a better risk of kidney injury. And obviously, we need to monitor this patient's kidney function over a period of time, so that even if there is an acute kidney injury, most of the times, like 3/4 of the 3/4 of the patients, the creatinine goes up, gets plateau, and gets better. So they cause a transient acute tubular necrosis kind of picture, and by day 4 or day 5, they start getting better. Looks like there are 25 questions. Should I answer them now, or should we just? There are just a couple of slides remaining.
We'll finish the slides, sir.
Okay, thank you. So next is vaccines. Because someone like kidney CKD stage 3 or 4 are at a risk of infection because of decreased immunity, and if they get hospitalization because of pneumonia or influenza, they suddenly land up from stage 3 to stage 5. Uncle was having creatinine of 2, got admitted, hypotension, and that one hypotension required him to pass over the edge and requiring dialysis. And at that stage, it is very difficult to accept that till last month the creatinine was just 2, and why the patient is on dialysis now, and the doctors are telling that he won't be coming out of the dialysis. Why so? So it's because he was underlying CKD stage 3-4, and at that stage they just need preventing each and every hospitalization, so that the another insult of the kidney injury will be lesser. So we need to give them vaccines. There are 4 vaccines which I prescribe in each and every patient of mine. That is hepatitis B, pneumococcal, Prevnar and Pneumovax, followed by influenza, which is once a year. And I give Shingrix in all my patients, because that is something more than a huge trauma to the patient than actually the benefits of cost saving in that patient. So all my patients, I suggest to get a Shingrix vaccine also. This probably will be last case to be discussed. She is a 58-year-old female, type 2 diabetes for last 8 years. HbA1c was around 8. Hypertensive for last 5 years. The blood pressure was around 150/80. She had a coronary artery disease, required stenting. The ejection fraction post stenting was around 45%. Renal functions not monitored regularly. Once in a while, she used to get a creatinine, which was around 2.5. And she was feeling all right. So she was thinking that she is doing great. That's what something I call as a Superman syndrome. Our patients feel that great, and they feel like they are Superman and they are not vulnerable to anything. Yes, and she was one of them. She presented with just complaints of decreased appetite, and she is like very close friend of my. She is very close relative of one of my friend. So if I see the risk factors, there was uncontrolled diabetes, uncontrolled hypertension. She had a proteinuria which was never diagnosed. She had anemia. Anemia worsens the kidney injury recovery. So if someone is having creatinine hemoglobin of 12 versus someone with hemoglobin of 8, obviously the oxygen delivery to the kidney will be lesser, and that's why AKI will be delayed in recovery. She was getting knee pain, so she was taking pain medications. She had decreased water intake because she thought that it will cause a more frequency of urination, so she used to avoid. And on top of that, she was on diuretics for the risk of LVF. These are her labs. She had a creatinine of 7. She had CKD anemia. She had a bone mineral diseases. She used to get recurrent infections because of the advanced kidney disease. There was no access created, and she started developing the uremic symptoms. That low appetite was one of the uremic signs. And at that time, at the age of 58, when she was so young, she was suggested to have a dialysis. And because the family never thought about it, that she had like so many issues, or because she was feeling all the great throughout, they never had a chance to discuss with her that what all she's going through, or evaluated for all her troubles. The word dialysis was such a trauma to the patient that she couldn't like accept it for a couple of months. Over a period of time, she got malnourished and landed in hospitalization, where she was in hospital for a month. And at that time, she accepted dialysis. But by that time, because she was so malnourished, she couldn't do well on dialysis as well. And then the family was describing that no, dialysis is not good. Obviously, dialysis is not good for someone who is malnourished or like recurrently infected. But if someone is like prepared well, got like all the parameters of kidney disease well corrected, in that patient, the dialysis is still is one of the life-saving. Here I would like to take a pause and describe that sometimes in initial part of the kidney injury, nephrologist may not change anything than any other doctor. Nephrologist will not be able to stop the progression if there is something which is ongoing. But yes, they will be able to predict what is the kidney damage and what will be the future. Sometimes that is what a patient needs to follow diabetes, hypertension management strictly to get their kidney functions evaluated, hydration, avoid painkillers, and get their vaccine. So that is something is like probably one time stop to prevent the like a cascade where there will be kidney injury causing vascular diseases, infection, psychological traumas, neuropathy, malnutrition, and things like this. Where nephrologists can help in the day-to-day practice. Anyone wants to comment? Okay. So where nephrologists can help. So first of all, if there is a abnormal kidney function without a significant reason, non-diabetic, non-hypertensive patient with increased creatinine, yes, there is something which is happening in the kidney which needs to be found out. If there is a rapidly worsening kidney function, diabetes is controlled, hypertension control, no proteinuria, but the creatinine is going up. Proteinuria, 2 years of diabetes, but significant proteinuria. There is something fishy over there. Active sediments, presence of blood and WBCs in the urine needs to be evaluated. If there are no urine tract infection symptoms, there might be underlying a glomerular disease, which we need to find out and treat early. There could be abnormal morphology on imaging. There could be initial cysts, which at the age of 20s, if there are cysts in their 20s and 30s, probably there might be just early presentation of polycystic kidney disease and needs management. There could be a family history. I got a family where mother is on dialysis and now her 20-year-old son is also on dialysis. And she never had a chance to get evaluated because she's from a rural background. The son is like still well read. He agreed for genetic workup and we found to have that he got Alport's disease from his mom. So now we know that for being on dialysis at the age of 20 with ESRD, end-stage renal disease, the transplant will be an option, and his family members from maternal side should not be a donor. So if there is a family history, we need to find out what is the cause. Optimization the kidney risk factors like diabetes, hypertension, proteinuria, but along with that to make sure that CKD anemia, mineral bone diseases, and neuropathies to be taken care. Access creation. If we create fistula in CKD stage 4, there is a very high chance of maturating it versus in CKD stage 5 or patient on dialysis. So access creation, which is very important. Doing transplants can like help the patient to avoid dialysis, and they can directly go from CKD stage 4, 5 to transplant as called as preemptive transplants. They need not to be on dialysis. The transplant can happen even at CKD stage 5, early stage. The nephrologist will be able to help in terms of choosing an option, whether there is a hemodialysis or a peritoneal dialysis, which needs to be opt for the patient or which will be better for the patient. And last, if there is someone is having a history of recurrent kidney stones like oxalate stones or fabric uric acid stones, at that time definitely these can help. Sometimes the patients with pregnancy having normal blood pressure. Normally, the pregnant patient should be having low blood pressure in their first and second trimester. But if they are having normal blood pressure or high blood pressure, this could be an early sign of preeclampsia or eclampsia, where the kidney function needs to be monitored before we complicate the things. So, as I mentioned that it is very much possible for Indians because we don't write emails to our colleagues. We don't send like mails or like fax to our colleagues just to tell the patient's condition. We can communicate directly. We can give a call to the patient's diabetologist or like family physician and say that now I have done the kidney part, but these all things you need to follow, and then patient will be able to take better care by like a team. And as I mentioned that practice and this communication better will help to have a good and better outcomes. Predictions. If we predict that which patients are going to worsen, the team can build together to take care of them. And that's what is something which is unique about the Indians. I stayed in Canada for 4 years. Even though patient was like followed by 4 physicians, we used to send a fax to 4 physicians to tell them that, okay, now this is the patient's condition. And that used to have like so many of lacunae which we can have like better handled in India over here. So thank you so much for opportunity again, and I'm happy to take any of the questions.
Thank you, Dr. Suhas Monte, sir, for a very nice and elaborative talk. Probably we have discussed everything, whatever you could in the given time, but we'll take up questions. Shall we, Rupa?
Sure. Please, sir.
Yes. And to begin with, sir, I suppose we'll begin with the eGFR calculation. Okay,
Yes, sir.
I know it's on the net. Okay, it's on the net, the Bancroft, whatever you call it. But can you, for the benefit of the viewers, just say what is the eGFR? How it is calculated from serum creatinine?
So estimated GFR, eGFR is estimated GFR. Actually, there is something called as measured GFR, where we actually give contrast to the patient, and by nuclear scan we understand what is the exact filtration of the kidney. But because it's a costly test and needs like more like elaborative study, what we do, we are having a formulas for a gender based, then age based, and creatinine based. We are arbitrarily understanding what is the GFR of that patient. That will give us an understanding how good the kidney function is. It's not the exact, it's the arbitrary number, but it is much better than to say that the creatinine is 2 versus to have a GFR of 60, because all the complications were explained on the basis of eGFR. Like the eGFR is between 30 to 60, these patients will start getting anemia. 30 to 15 will start getting bone mineral densities problem. So that's why estimated GFR gives us understanding what is the stage of kidney damage for that patient. And this is freely available. You need not to go to the lab. You just need to open National Kidney Foundation. Just go over there, put your age, gender, creatinine, and that's it.
Okay, sir. Thank you. And now, since we are talking about chronic kidney diseases, the second question would be diabetic nephropathy is the most commonest. You would agree.
Yeah.
Okay. So the second question is, what are the risk factors which determine the progression of diabetic nephropathy to ESRD, apart from hyperglycemia?
Perfect. So I'll tell you the first and foremost, because which are unique for Indian population. We are probably the maximum number of low birth weight babies in the world. So low birth weight babies will be having low nephron mass. So they are born with the lesser number of nephron themselves. And on top of that, when these patients will start getting diabetes, initial period also when they are having not hyperglycemia but euglycemia or just borderline hyperglycemia, they start leaking sodium in their urine. And in the sorry?
No, there was some interruption. Yeah, you can continue.
So sodium will be reabsorbed in the proximal tubule along with salt by the same channel which dapagliflozin inhibits. And that channel absorbs salt and glucose. And because of that, these normal patients who are just diabetic or borderline diabetic will start developing increased risk of hypertension also. So only plain diabetics also over a period of time are at a risk of getting a hypertension. So low birth weight babies decrease hydration. As I mentioned that glucose itself is a diuretic. So if they don't hydrate well, but their glucose is very high, these patients are always like in the stage of like getting diuretics. So if you see their uric acid, it will be on a higher side. They'll complain of cramps all the time. So it need not to be hyperglycemia to affect the kidney function. And along with that, there are like these patients, as I mentioned, that there is something called as interstitial nephritis also. Suppose there is like there is a worker who is working in the farm. Okay. Very commonly the sugarcane factories. Okay. These are working at a very high temperature in a humid state. Okay. They will be having, first of all, dehydration because of sweating. On top of that, they will drink something which is a sugarcane juice, which is nothing but just glucose. They will be having diuresis. They will be having more and more salt and glucose lost in their urine. Will start getting cramps. To avoid that cramps, they will be taking painkillers, which is the easiest form of like relief. And they will be affecting their kidneys much more robust than anyone who is like having like well proper hydration and avoiding painkillers. So there are not only one factor, but there is a cascade of factors which will be responsible for causing CKD.
Right. Okay. That brings to us a very interesting thing. What drugs should be avoided in CKD in general, apart from analgesics, you said, and diuretics, obviously.
So to be very honest, it's not that we need to avoid, we need to see the risk versus benefit. Acute kidney injury will be caused by AC inhibitors and ARBs, I agree. But AC inhibitors and ARBs are one of the best drugs to have proteinuria under control. So we need to be cautious about starting them. We need to make sure that the creatinine is well checked and we are following the creatinine rise. We are making sure that patient is hydrating well. And that is something which is very essential. Dapagliflozin, another best medication in the world for preventing progression of the kidney disease, diabetic kidney disease or non-diabetic kidney disease. Nowadays, there are evidence that this can be used in any of the proteinuric non-diabetic kidney disease also. But the problem is that the moment you start these patients on dapagliflozin, because they don't keep the good hygiene of their private part, they start leaking glucose in their urine, which will attract more fungus and they present with the fungal UTI. So I will say, apart from NSAIDs, there is nothing which is like contraindicated. Yes, there is a caution mark, and with the caution, if you are monitoring these medicines, there is nothing like which are like harm about this medication. They are probably the best medications also.
Okay. Then how frequent should be the monitoring? Once we start them on, say, metformin or whatever drugs, probably, how frequently should we monitor the kidney parameters?
So what I do, I monitor one, like if I start dapagliflozin or AC inhibitors or ARBs or metformin, after a week, I ask them to get a urine routine, blood electrolytes and serum creatinine. The reason is that if dapagliflozin is there, urine routine showing glucose plus, that means the dapagliflozin is acting. If
Okay.
the urine electrolytes is working, blood electrolytes is normal, there is no hyponatremia, that means it's been well managed. And the third thing, if the creatinine is not rising too much, there is not much of interaction which is happening. Sometimes these patients don't tell us, but they take multiple pathies also, which also act in a similar way, like a diuretic or ACE inhibitor, and there should not be an interaction. To be very honest, I don't know what other pathies work and how they work. Definitely they work, which we have learned over a period of time. But if the creatinine is not rising, that means there is no interaction which is happening for that drug. And then I'm happy. Then I just do it like once in a month or once in a couple of months. Then I'm good.
Okay, the first month, you mean to say the first week is important.
First
The
week is
moment you
important
start.
because the drug gets achieved its therapeutic level after 3 dosage.
Okay, fine.
So after 3 dosage, the drug is achieved its level in the blood. Then I'm not worried. Then I ask them after 4 days to get a creatinine and electrolytes. And if creatinine and electrolytes are good, I'm good.
Okay, fine. So now probably continuing with the same thing, what will be the drug of choice for patients in CKD while treating diabetes, supposing?
So depends on the stage. There are some medications which are very much good in the initial stage, like metformin, probably the best drug for diabetes in initial stages. Yes,
Okay.
but not all of them can be applicable in CKD stage 4-5.
Okay.
Right? So like dapagliflozin, I'm hesitant to start dapagliflozin if the GFR is below 20.
Okay, fine.
Right? For metformin, I'm not very comfortable starting metformin if suppose GFR is around 15, creatinine goes up to 4, probably I'm not that comfortable. I'm happy to use like GLP-1 analogs also. I use GLP-1 analogs, they are good. Insulin is probably the best in the advanced kidney disease. But apart from that, I'm not like too picky about the medications in general.
Okay, fine. Now, fine. Generally, we as a primary physician come across people with CKD along with the, say, fever probably. So what should be the drug of choice of first line antibiotic therapy probably? In CKD patients we are talking about.
So the main reason is that these CKD patients are at low immunity. So they tend to get infections.
Right.
Okay. Every infection, if there is a hemodynamics involved, they will lose some kidney function.
Right.
They will not be having only CKD, they will be having all the time acute kidney injury on underlying background of chronic kidney disease. Okay. So the treatment management will first find out the cause.
Right.
If this is something bacterial, treat it hard. Probably you will not get that much amount of GFR later, and probably as the GFR goes down, you may need to decrease the dose of the antibiotics. Okay. The drug for fever is always paracetamol or acetaminophen. Okay. If someone is having underlying liver trouble, then I'll be more cautious. But definitely, I'll not use any of the naproxen or ibuprofen, NSAID, or even like any other like anti-inflammatory agents also. Steroid to be used in these patients, I'll be very, very, very hesitant. I'll not use them because kidney patients are, first of all, are having very weak bones. Multiple steroid episodes will be like an invitation for fractures. So I will not use them in most of the scenarios.
Okay. Would you like to comment something about diet in CKD patients in general?
Yes, actually, it will like probably a topic itself. One essential thing which I have noticed is something that dialysis or kidney disease is not protein contraindication. Okay, even though patient is in the advanced kidney stage, disease stage, still there is a recommendation of taking 0.6 gram per kg per day. So for someone of the age, like weight of like 60 kilos, he still needs to take almost 35 to 40 grams of protein in that scenario also. What will happen if he is not taking? What will happen if he is not taking? He will start losing muscle mass. There is something called as a sarcopenia, uremic sarcopenia. They will start losing muscle mass, and because of that, because the muscle mass is decreased, the creatinine generation is good, and like lesser, so they feel that the kidneys got regenerated. No, the kidneys have been the same before. It's just that the creatinine which was generated by the muscles was gone down, and because of that, the patient is now malnourished. The patient who was earlier came to you walking, he started using a stick. The stick patient was started using a wheelchair. Now the wheelchair patient was brought on the like a stretcher. That means that just to decrease the creatinine generation, we have made the patient malnourished, which is probably the worst thing. In that 36 gram, even though he wants to take, there still be like what I will be suggesting them to have is like a 2 white eggs. If the patient can have half glass of milk and like half of what bowl dal, which is probably still like a good amount of protein content for that patient. But if the patient start taking zero protein, patient will land up in malnourishment. And the patients who land up in malnourishment, they don't do good on CKD, they don't do good on dialysis, they don't do good on transplant. They will be having poor outcomes. So protein restriction one. Second is salt intake. Because this patient, salt acts like a sponge. If these patients take salt and take antihypertensives, the effect of antihypertensives is in vain. So what I suggest that make sure that your salt intake is less, so that you will be having a less water retention. Third thing, depending on the urine output, if someone is like making huge amount of urine output, I'll make sure that they will take urine output plus few hundreds of water, so that the patient doesn't go into dehydration stage and doesn't definitely go into the fluid overload stage also. The last and foremost is depending on the potassium. If the potassium is low or normal, I don't restrict all the potassium containing diet. I want them to have, because sometimes they carry minerals, nutrients, vitamins, which will help the patient well-being. So these are something which I will definitely tell to all my patients.
Okay. And coming to monitoring of this thing, how frequent should be the proteinuria should be monitored, or microalbuminuria should be monitored in a diabetic patient?
So first of all, it depends on what scenario. If there is a diabetic, hypertensive, and having proteinuria of probably a gram, first initial I'll get a 24-hour urinary protein.
Okay.
Because for me it's a baseline. And on top of that, once I start treatment with ARBs or dapagliflozin, there are only 4 medications which decrease proteinuria. First is ARBs or ACE inhibitors. Second is dapagliflozin. Third is newer medication called as Finrenol, which is having a good data. And the fourth one is the GLP-1 analogs. So these are the only 4 medications which are proven to be decreasing proteinuria. So depending on the need, I'll add one, escalate the dose, add second, escalate the dose till the patient tolerates. And the proteinuria which was monitored 24 hours, I'll make sure that I'll see ACRs, like albumin creat ratio, every month, and probably in a couple of months, like 3 to 4 months, just to verify that I'll get a 24-hour urinary protein. If there is a persistent drop, then I'm happy. I monitor the like albumin like once in few months only.
Okay. I think there were some questions in the chat box. Shall we take them?
Sure, sir. Sure.
Not many questions in the chat box. So Dr. Nitin as well as Dr.
Sorry, I'm not able to hear.
Is my voice audible now?
Yeah. Yes.
So
Yes, Rupa ma'am.
see that there are lot many questions in the chat box. So
Yes,
I
yes.
do it fast thoda, ताकि
Yes,
हम
yes.
Definitely. Sure.
And
We'll
now,
start from the first.
yes, tell me Satan in CKD, when to stop? The question is.
Whenever there is a rising creatinine is too fast and there is a hyperkalemia happening, I'll stop. If there is hyperkalemia with ARBs, I'll hold it. Because patients don't come that regularly. Patients sometimes miss their follow-up and come after a few months, and by that time the hyperkalemia could be life-threatening. So the moment I see hyperkalemia, I stop it.
Okay. 23-year-old on high on protein diet has creatinine of 1.2. What do you advise? HbA1c is 4.5. Is it of concern?
23-year-old, depending on how is the muscle mass. If the muscle mass is like huge, Dara Singh or a bodybuilder mass, then I'll get a cystatin C, which is a non-muscle dependent creatinine, like a formula for EGFR. It doesn't need creatinine. It will give your EGFR. If EGFR is normal at that case, I'll not be worried.
Okay. tramadol or paracetamol, is it safe in CKD?
Yes. Tramadol just causes nausea, and these patients are already nauseating, so probably I avoid. But paracetamol, yes.
Use of hematinics and calcium in CKD patients, please comment.
So hematinics, yes, there is a need because CKD anemia needs erythropoietin and iron. But if someone treats only erythropoietin or only iron, doesn't help. So first of all, I check transferrin saturation, that's iron content in the blood. If it is like adequate, then only I start on erythropoietin. Calcium, yes, because if you hold back the calcium, even though it's normal, sometimes the parathyroid hormone goes up. So calcium all the times remains normal. But the only trouble is that PTH or parathyroid hormone goes up to maintain that normal calcium in blood, which makes more like vulnerable fractures. So yes, I treat with calcium with monitoring of the phosphate and PTH.
Okay. If serum creatinine 2.6, should we stop lepafloxacin?
At what age? If the GFR is dropping below 20, yes, I will stop.
Okay. Which side you mentioned? Okay, fine.
Actually, sorry to add, there are studies which are currently going on to give it in even dialysis patients, but they have not been approved yet. So if someone wants to use, make sure that they are discussed with the patient that the role of these medications, because patients don't get that good amount of urine output at this level. They just pass water. They don't make urine. Good urine means there will be water and toxins in the urine. These patients at CKD stage 4, 5 will be passing water. They don't pass good amount of toxins into it. They accumulate in the blood. So that's why the urine output is not that like a best marker for them to keep on giving dapagliflozin.
Then how do we monitor, sir?
What to monitor?
You said whether the patient is passing urine or water, probably. How do you differentiate? By doing urine routine?
Patient tells that he is passing urine, but
Right.
that is not urine. What urine should be? Urine should be water plus acids,
Okay.
anions, cations, and toxins.
Okay.
But,
Okay.
but these patients are not having good filtration, right? So they just pass water and everything just builds up in the blood. So this is not a good quality urine. What a good quality urine for a nephrologist is something which is looking yellow. There is like toxins, good amount of toxins into it. The blood urea, blood creatinine is normal. That is something which makes us happy.
Okay. So you must do proper urine routine, not rely on patient itself.
Yeah.
Yeah. Okay. Now this says which site you mentioned for calculating EGFR.
National Kidney Foundation, National Kidney Foundation.uk. It's a free site. You can use it. There are like many of them. You just put EGFR calculator. There are many of them. They use same formula from National Kidney Foundation.
Okay, thank you. Then there is a question called CT coronary angiogram. Is it safe to do in CKD, as it uses less dye to perform the procedure? CT coronary.
So again, CT coronary or actual angio, if there is a need to do it, do it. Because if there is an ongoing ischemia of the heart, and if you don't treat, that ischemia heart itself will cause AKI. That is something called as cardiorenal syndrome. Poor heart giving rise to kidney damage. Okay, so that's something. If there is suspicion of high like ischemia, go ahead and do it and monitor the kidney function. Give good hydration. Use the most like radio opaque like Omnipac like isoosmolar dye and do it. Because if you don't treat it, the patient will end up in LVF and will develop AKI itself.
Yes, certainly, sir. Okay, then there's one question: is banana safe in CKD?
Depends on the potassium of the patient. If someone is having tubular disorders, the potassium will be low. We ask them to eat bananas, right? So it depends on the cause of kidney disease.
Right. Paracetamol can we give for? Yeah, you already answered it. Paracetamol can we give for long term in CKD?
With regular monitoring of the liver function. If suppose someone is alcoholic and having underlying liver disease itself, definitely the answer will be no, right?
Yes. And then the last question is, in CKD, how frequently should we check serum creatinine? You have already answered, I suppose.
So if like CKD stage 1, 2, and 3, once in 6 months, CKD stage 4 every 3 months, CKD stage 5 every month.
Okay. I suppose I missed few of them. What is
Okay.
debris in urinary bladder? This says.
Sorry, what is?
What is a debris in urinary bladder?
So debris in urinary bladder is, suppose someone had a urinary tract infection or a cystitis, there will be sloughing of the like epithelium of the bladder, which will be seen in the like ultrasound. Once you put the probe, there will be like echoes which will be seen on the like full bladder. That is called as debris. So that could be like active bladder infection versus like a remnant of the previous, depending on that what site or what symptoms the patient is having.
Yes. Okay. Then there's a question called 38 years old diabetes mellitus type 2 on tab metformin plus glimepiride twice a day has proteinuria. Please guide.
So what is the quantification of the proteinuria? If it is like 30 milligrams, keep on checking the sugar, make sure that he is not hypertensive, add ARBs. If the proteinuria is like 4 grams and the diabetes is since last 2 years, definitely this is not because of diabetes. There has to be something else which is happening in that kidney.
Yes. Yes. How long one can tolerate NSAIDs? I don't know.
How
Dr.
long
Ravindra
can
Sheth.
one tolerate what?
NSAIDs. NSAIDs.
Probably my answer is none.
None.
I'm worried to take even one. So,
Right.
so if someone needs to give it, make sure that there has to be good hydration. If there is hydration which is poor, I mentioned I've seen many patients with a single dose of injectable Voveron, they have lost their kidneys.
Right.
So the answer is 0.
0. Yes. Yes. There's one more question which says, does drinking more than 3 liters of water per day damage kidney in normal individual? How much water intake is sufficient?
Again, this question, to be very honest, varies person to person. So myself, I sit in AC all day. I come from home, I sit in day throughout in AC. Probably I don't need much. The same person who is working in bank probably needs more because he needs to travel. The someone who is like playing cricket, he will be taking more. 2.5 to 3 is a good number for someone like me.
Okay. Okay. Then there's a
And
last
more than 3
question.
liters will not harm the kidneys for sure.
Okay. 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 This is, I suppose, the last question. SGLT2 in CKD, is it protective? Oh, you have asked.
Exactly, yes, 100 times.
Yes.
If people are like taking care of more like urine tract infections or fungal infections, we should be like prescribing it like every possible kidney patient to help their kidneys.
Yes. Yes.
If there are no
May I
interactions.
ask one question? May I ask one question?
Sure,
Yeah.
sure.
Yeah.
Sir, when there is a proteinuria in urine, there is a 4 plus protein, and his urine is foaming after passing for 10 minutes. What will you advise, sir?
Quantification of the protein, how much grams the proteinuria is there?
4 plus.
4 plus doesn't mean anything. If there is a concentrated urine, that even like a 500
No
milligrams of
concentration,
protein.
no concentration, normal urine, but just it gives form for 5 to 7 minutes after passing urine.
Exactly.
Patient is
Get the
diabetic.
24-hour, yeah, exactly. 24-hour urinary protein to be done. If this is nephrotic, definitely it will be more than 3.5 grams. If it is lesser than that, then we need to find out what is the cause. If there is a diabetes or hypertension or active kidney disease which is causing that proteinuria. So proteins come in the urine only if the filters get damaged. And that means if there is a protein loss or foam in the urine or 4 plus protein in the urine, that means the filters are getting damaged. The only question is that why they are getting damaged, how to prevent them.
Diabetic for last 22 years.
And how was the control?
Uncontrolled, obviously.
Sorry?
Uncontrolled, sir. Because some never his HbA1c is below 8.
Okay, so as I mentioned that yes, that could be just because of the diabetic nephropathy. Okay, what I will do if my parents are having this condition, I'll do their ophthalmic checkup. I'll see that there is a retinopathy. If there is a persistent retinopathy and there is such a huge proteinuria, I'll rule out myeloma. And if I'm ruling out myeloma and there is nothing else, I'll accept this as diabetic nephropathy. Yes.
Thank you, sir.
So will you please elaborate on the albumin creatinine ratio? It's important to monitor the kidney progression.
Yes. So albumin creatinine ratio is basically what I will say as like a follow-up marker. If suppose patient is not able to give 24 hours of sample because of some reason, At that time, just to understand that how much he is responding to our treatment, we do albumin creatinine ratio. Or suppose we need to understand like over like a population level that how much of them are having proteinuria. At that time, we use this test. But this is a very not that specific test. Suppose patient is like having concentrated urine, the same urine sample will show proteinuria and ACR will be high. But if there is a two dilute sample, the same sample will show that there is not much of proteinuria. So there are like too many variants. Sometimes like if the patient like gives the sample after walking like certain distance, by doing that muscle activity, he starts losing creatinine in the urine, and that will decrease the ACR. That doesn't mean that his kidney's gone better. That just means that he has passed more creatinine in the urine, right? So it's a ratio. There are so many fallacies about this ratio. If there is a chance, I will definitely 100 times will get 24-hour urinary protein just to understand, because that will rule out all these possibilities.
Thank you, sir.
So someone mentioned that my question was
Can
not
I ask
answered.
a question?
Yeah.
Okay. Male patient, 66 years old, say last 25 years hypertension, from 2006 diabetic, known CKD now like for last 4-5 years. And now the creatinine from 2-3, it has come because the diuretics were increased because of swelling in leg and all. Suddenly from 4-5 it came to 8 and 9. So now the dilemma is whether one should start dialysis or no. Like
Whether the axis is being created, fistula.
yes, fistula is created.
Perfect. If the fistula is created and the creatinine is 8-9, probably I'll use the dialysis. Okay, and I'll tell you why. The frequency of the dialysis per week will be lesser in initial period if we start without symptoms. That is something called as incremental dialysis. For a few months, the patient will be having just once a week dialysis. But by taking out these toxins, his immunity will be better, his appetite will be good, he will not lose his muscle mass, so there will not be sarcopenia. He will be able to get vaccines, okay? And if he is 66, probably he can be listed for the transplant also. So that scenario is much better than to wait for the creatinine to go up to 12 and losing muscle mass, losing again 7-8 kilos of weight, starts vomiting, not able to like eat and like drink, legs are edematous, not able to walk, imbalance, falls, fracture, nausea, vomiting, confusion. So all those problems will be avoided by just starting early dialysis.
Okay. So it is advisable to go in for dialysis rather than making the wait. Because
One more question, sir.
Sorry,
One more question, sir.
I couldn't understand. I'm really sorry.
No, the question
Give me a
is
second.
like
Give me a second. Give me a second.
so the question is it is better like because the patient is in dilemma like whether to start dialysis or no.
In that situation, I will inform the patient and I will convince why starting early is better than unnecessarily delaying and complicating the things. Because there are huge amount of data shows that later the dialysis, poor is the outcome.
Okay. Because before dialysis were done in January and the patient improved. And then now, like the patient is saying, ki, okay, 2-3 hi kar lo, and then I don't want to go in for regular dialysis. So is that possible?
No, actually not.
No.
This is just the patient psychology. By doing 3 days dialysis, his kidneys have not gone better. Dialysis doesn't help the kidneys. Dialysis just remove the toxins. So his kidneys are the same as it was.
Yeah, right. In fact, yes.
So
Okay.
one more question, last question, sir,
Thank
please.
you.
No
Hello.
Hello.
Yes, sir.
I'll give my number.
Will you
If someone is having a call,
advise dialysis? Will you advise dialysis to epileptic patients if they are
yes,
on medication?
yes.
It's
Suppose
not
there is
going
suppose there is a CKD stage 5. There is a patient of mine who's a CKD stage 5 and the age 18. And she's epileptic.
Yeah.
So for me, that she should live. She should have like education, she should work, she should do her job, she should get like marriage, should have kids, she should live. So yes, I will advise her.
That won't let that concentration of sodium valproate go down.
So at that time, I'll use the medications which are not renally excreted or which are not affected by dialysis. And if at all they are getting affected, I will ask them to take an extra dose after the dialysis.
Okay, thank you, sir.
Thank you so much, Dr. Swaz, sir. Thank you so
Hello,
much.
sir.
I suppose we'll
Hello.
wind it up.
Hello.
Sure. If someone is having questions,
I will
just
write
call me directly.
Hello.
I'll be
Hello,
happy to
sir.
answer.
I
Hello,
will
sir.
write sir's number on the chat
Hello.
so that.
I'll put. Don't worry, I'll put.
Hello, sir.
Yes,
Hello,
yes.
Sir, in this young patient who are taking lot of protein and going to the gym, is
Yes.
this high protein diet the cause of the high creatinine, as I asked you in the patient with the 1.2 creatinine? A normal healthy person going to gym with lot of high protein diet, lot of eggs and chicken. So is this harmful, and that is the cause of 1.2 creatinine with good muscle mass?
I'll tell you one very famous celebrity from Indian cinema gained muscle mass for one of the movie. Okay, he was very much appreciated for his work. Next year he did another movie where he has to lose like 30 kilos. The second part of the first movie came, he gained again like huge amount of muscle mass, and by the time of release of second movie, he lost his kidneys and he required dialysis and transplant. So if at all you're like putting out too much of proteins on the kidney needs a huge amount of water also to digest it.
Okay.
They don't just take proteins, they decrease less water. They make your kidneys more concentrated. Even some of them take creatinines. As I mentioned, one of my patients was a politician, local politician. He used to get veterinary vitamin D for muscle buildup. We don't know how many of them are still taking anabolic steroids. Right? So I think that being healthy is much more important than to live muscular and hung. So that is probably my take. I will not be very happy if I gain like 50 kilos of muscle more. No, if I need to do that, it has to be done from the age of like kindergarten. Everyone cannot be Arnold Schwarzenegger at the age of 30. No, your kidneys are meant up to be for your 60 kilo weight. If you try to be 100 kg, your kidneys will say bye-bye.
Yes, thank you, sir.
Thank you, Dr. Suhas. Thank you so much for your time, and it was very nice and really enjoyable to interact with you. Now,
Thank you so much, sir.
I request Dr. Prakash Mahajan sir, to say a vote of thanks.
So before I tell you, say the vote of thanks, sir, I want an advice from you for general practitioners. See, what we have got in, let's say in cardiology, we have got a EC machine. So we can early make an early diagnosis of some heart problems, right? Likewise, we have also in cancers. So we have got some policies, so we can detect cancers early. What advice can you give for general practitioners to have a high index of suspicion, or they should conduct a specific lab test, or what is to be done in a clinic, in a general practitioner OPD, so that we can diagnose these urological cases early?
Okay. Sir, I'll tell you just one more point. It may take like a couple of minutes more for me. I'm sorry for taking time. But sir, nephrology practice is not like cardiology or oncology. The moment patient goes to a cardiologist or oncologist, he starts his treatment, and after that, most of the time, the patient loses contact with the general practitioner or the family doctors. With the nephrology, actually, the patient needs support of the nephrologist as well as the general practitioner throughout their life. They need this discussion at the time of starting of dialysis. They need this discussion at the time of getting transplant workup. They are depressed. They need someone to talk about. They cannot explain or they cannot be opened up with the nephrologist who has they known just for 2 minutes. or like just 2 weeks, they will be able to open up with you guys. There is a patient of mine who is getting dialysis downstairs. He's a driver. His occupation was driving. Now he's being on dialysis. He cannot drive. He has lost his job. He got like 4 people to feed. He is in depression. He won't be able to open up with me, but he will be open up with you. So they will be needing the required like discussion with you guys as well as with like us. And probably we are the one who need to talk more while taking the collective decision for the patient. At that time, when you ask that how in practice you will be able to find these patients early, there is only one answer, sir. There is just high clinical suspicion. This creatinine is not good for this muscle mass. That understanding will trigger the thought that, okay, there might be something else to this. Problem is that, sir, cardiologist and oncologist has sell their branches so well. If there is a chest pain, they will be like, patient will not come to doctor initially, family doctor, no. They'll go to the most like emergency and get their ECG or like even nowadays there are patients who tell that get my angio done. Because so many celebrities, film stars, politicians got cardiac issues. So many celebrities got cancer. So the general public is more aware about these diseases, but they are not aware about the nephrology. In our nephrology practice, we always say that when there will be like 5-6 politicians will be getting kidney disease, then normal public will start understanding about the kidney disease. People knew about CRRT by Jayalalitha. People knew renal transplant because of Lalu Prasad Yadav, because of Sushma Swaraj and Arun Jaitley. Till that time, they were not knowing that even Rajnikant had kidney transplant, right? So that's how like normal people are. So high suspicion of kidney disease itself can help you to identify these patients. There is no harm. Like if you select 10 patients, 8 might of them will be having normal kidney function and you need not to worry about that. But 2 that you will catch, you will save their life forever. Detecting kidney disease in early your practice will save their progression of the kidney disease. You will protect them from dialysis. You will protect them from transplant. There is a treatment available for the glomerulonephritis which can save them. The only problem is that they come to us when the creatinine is 4, when the GFR is dropped to 30, where the kidneys are scarred already. We can't treat that. The patient will come to you at that time. And that is the time when you will be able to make the huge difference in patient's life. If I say that nephrologists do the like biggest change in the patient's life, no, probably not. Probably you are the one who is doing major change in the patient's life than me. So there is a rule in like Canada where I was, any patient with a GFR of 60 with normal kidney function, with abnormal kidney function, refer to nephrologist. Probably the nephrologist will send you back saying that nothing of mine, please take care. That's good. But if there is something that needs to be picked up at the age of 6, at the GFR of 60, there is a chance for nephrologist to treat. But if you lose that window, the patients come to you at GFR of probably like 25 or 15, not much a nephrologist can offer to this patient. There is a patient of mine who is a kidney transplant recipient. He is a doctor himself. Father is a doctor, mother is a doctor. He is the only son of them who presented with me creatinine 16. No symptoms at all. He came, he sat on my table and said that, sir, tell me how to prove this report wrong. And I said, I can't. Now this patient has gone transplant. He has done transplant. Father gave to him. He is doing great. But if he would have checked his creatinine himself a few years back, probably he would have noticed that there is a rise in creatinine. I should go and visit a nephrologist. Sorry
Yes,
for
sir.
you taking time. I'm really sorry.
Nice, sir. You explained it really very much scientifically also. At the same time, you explained it from the bottom of your heart, very passionately also. And of course, you gave very illustrative, very relevant illustrations to explain your point. And you really could put across that particular point to us. Thank you very much for that. And sir,
Thank
you
you.
mentioned about that Superman syndrome and that Superman patient that we have. I think today you have, of course, not purposefully, you acted like a Superman. You answered superhuman questions in a marathon way. There were so many questions, I think, about 50 questions were there. And the attendance also, it crossed 100 once, and then it came down to 90, 100, 102, like that. So that is also something like a Superman. And you're not tired still. That is also like a Superman. So,
Sir, the longest conversation that I had with one patient was 6.5 hours straight.
okay.
So this is nothing.
Yeah, and that is
He
super knowledge.
presented with creatinine of 8. He was like 27-year-old guy, newly married, wife, and he came to me with creatinine of 4.
Okay.
He thought that because he did a love marriage, that's why his kidneys failed. I spoke 6.5 hours straight. So this is comparatively nothing, sir.
Okay, good. That's very nice to know about yourself. So thank you very much, Monte sir. It was really a nice session, very informative session, and we can definitely have a repeat of this. And thank you all the MCF team.
This all goes
Dr.
credit
Rupa,
goes to Rupa madam.
Dr. Gayatri, Rupa, everybody from MCF team, and of course, thank you all the participants who always attend in huge numbers. But today also they attended in very huge numbers. They asked many questions. They are all interested, and they are coming because they are interested in learning, and that's why MCS stands for. We try to teach them what usually nobody else does. That is their philosophy, right? Thank you very much. Thank you much, everybody.
Sir, I'll tell you one more thing. If there is a patient in your OPD and you got a suspicion, give a call. Okay, probably I'll not see the patient, but at least I'll be able to guide you what investigations you need to do.
That's very kind of you, very gracious of you. We'll be doing that.
You. Take care, sir. Thanks.
Yeah.
Bye.
Thank you,
madam. Thank you so much.
Thank you.
It was really, really nice and very much to the level of general practitioner. That is the main thing I was worried for, and you proved me wrong. So yes, I'm very happy about this.
If anyone likes good coffee, come to hospital. We have a good coffee.
Sure, definitely.
Take care, sir.
Thanks
Okay,
to
thank you.
Gayatri and
Thank you,
Dr.
bye.
Nitin for
Thank you.
making this workful session great. Thank you all of you. Have a great evening.
Thank you, sir.
And once again, request to all the participants to make sure that you register for Medicon, because we will try to bring a good content in the scientific aspect for the conference as well. Thank you. 9th of